really excited. I'm really glad we could all get together to have we're recording the meeting. Don't say anything scandalous. Try not to. Nothing about H&H sign of labor relations. Welcome to Joint Grand Rounds. We have a speaker from UCLA. She's EM critical care, Dr. Sarah Krager, who's a phenomenal ICU critical care educator who gave grand rounds for us at the emergency medicine conference yesterday. And thanks to Julie, we were able to do a joint conference for our IM CCM folks here at Elmhurst today, and all of the Sinai CCM folks who are on Zoom as well. So Dr. Krager is from Yale Medical School, UCLA Emergency Medicine Residency, and Stanford ICU Fellowship, and currently works in CTICU, CCU, MICU, and various hospitals in the UCLA system, both in Los Angeles and Antelope Valley, and has a phenomenal website full of ICU teaching goodness called ICU EDU, and is going to talk to us today about reconceptualizing shock. So welcome her, please.
Awesome. All right. Hey, everybody. It is awesome to be here. Everybody can hear me, microphone, not too loud, not too soft. Fantastic. All right. Let's talk about reframing shock. So you just signed out, and then you get this call from the ED, and it's an ICU admission, and they call you about Mr. Smith. And Mr. Smith is 56. He has HIV, and he comes in with a solid fever like 39.2, complaining of shortness of breath. He's hypotensive, his lactate is high, his chest x-ray does these multifocal infiltrates. And they give him 3 liters of fluid, and the blood pressure's not improving. And they even do an echo, and they call you and they're like, look, I did this echo, I gave him fluid, and I checked his heart. The RV looks good, the LV looks good, and he's now maxed on norepi, and his repeat lactate's 5, and he's not making any urine. What I discovered when I started seeing these kinds of patients in the ICU, oh, am I echoing?
I'll unmute you, save the recording.
Oh, here, do you want me to? There we go. Better?
You sound perfect on Zoom. There's no echo.
Oh, I sound perfect on Zoom?
I just want to make sure the recording.
Okay. We're good? Okay, fantastic. We are good. Okay. So anyway, when I started having patients like this as an attending, and I didn't have my own attending to tell me what to do, I started realizing that the way I was approaching shock was just not sufficient to confront a lot of the clinical problems that I was seeing. And so in general, when we have complex, difficult clinical problems, what approach should we be taking to improving our approach to these problems? And often our instinct is fancier technology. There's got to be a device that's out there, or a device in development that we can use to solve this problem. Or maybe we just need to do some more research, and there's a paper that's going to come out and the conclusion section will tell us what to do. Or hopefully one day they'll come out with this nice algorithm and we can stop thinking and just follow the arrows. But I would actually argue that especially in critically ill patients, those things may be necessary, but are definitely not sufficient. And that really one of the things that's just as important is we need to improve our physiologic reasoning abilities. And in the case of these complex shock patients, what that means to me is we need to start thinking about shock differently. Now, the traditional way that we learn to think about shock, or at least I learned to think about shock, was in 4 categories. You have your hypovolemic, distributive, cardiogenic, and obstructive. But the problem with that is that that just leads you to say, well, which one of those boxes should I put my patient in? And that makes some big assumptions, like they only fit in one box, or that whatever precipitated the shock is what is currently driving their main shock physiology. Now, the other problem with these 4 hemodynamic boxes we put people in is that it's not great at the bedside for trying to figure out which kind of shock they might be in, which is why we came up with this clever pipes, pump, tank model. And that is much more conducive at the bedside to ultrasounding your patient and working through what might be causing your shock. The problem with this, of course, is that ultrasound is merely a tool for gathering data. And then if the only way you have to organize that data is to put it back in the same old boxes, you haven't really gotten yourself very far. Now, this isn't just something philosophical because I needed a topic to talk to you guys about today at Grind Rounds. This actually has management implications. Why? Because once you put your patient into one of these 4 categories, you only kind of have 4 things you're supposed to do. If it's hypovolemic, give volume. Distributive, give some pressors. Cardiogenic, you give them some inotropes. And obstructive, you decompress whatever obstructing things. Same thing with pipes, pump, tank. If it's a pipe problem, pressors. A pump problem, inotropes. And a tank problem, give them some volume. But what if you've done all these things? You're like, okay, I did the first one and it didn't work. I gave the second one and no, it didn't work. I did the third one and I'm still not getting anywhere. And you kind of end up in one of these moments where you're like, what's next? And when I did my ED residency and I was still in the ED, what was next was I called the ICU to be like, your problem. But then the second I was an ICU fellow, I was like, oh, wait, oh man, this is now my problem. And that's when I started realizing that I just wasn't really equipped to solve this problem. That my mental model of shock was insufficient, which is why I think we need to start working with it. And the place to start, or at least the place I think we need to start, is really embracing the concept that shock is not about hypotension, shock is about hypoperfusion. And we like to think that those 2 things are inextricably linked, that if your blood pressure is good, you perfusion. If your blood pressure is bad, you're not perfusing. But unfortunately, that's just not how this works. You can have a patient with a perfectly fine blood pressure that is not in fact perfusing their tissues. Alternatively, you can have a patient with a not so fine blood pressure that in fact is doing fine and perfusing their tissues. And at the end of the day, which one of these 2 things do we actually care about? Well, tissue perfusion, of course. That is where the magic happens. But practically speaking, the problem with this is that if you equate shock with hypotension, that is a great way to miss your golden hour. We talk about the golden hour mostly in the context of trauma, but really any sick patient, and especially patients with shock, have a golden hour or a golden some amount of time. And if you can recognize what's going on and aggressively treat them and resuscitate them before they fall off the physiologic cliff, they're going to do better. And not just are they going to live or are they going to die, but are they going to be in the ICU for 4 days or 4 weeks? Are they going to walk out of the ICU and go back to their life, or are they going to end up trached and pegged in a SNF? It matters that we use this golden hour well. As such, I think we need to become much more sophisticated about how we think about shock. So in my approach to become more sophisticated, I've decided to draw you a picture, a sophisticated one. Pretend this is you, and you are standing on the edge of a raging river. Now, that right there is your patient. And your patient is swimming really hard upstream really fast because your patient realizes if they don't do that, there's a really unfortunate waterfall, they're going to fall off. Now, I want you to picture for a moment, you're swimming upstream or running uphill or biking uphill, and you're starting to get tired. And you get tachypnic, you get tachycardic, you get hypertensive, you get diaphoretic, and then eventually you are so tired, you just can't keep going. That is the difference between compensated and decompensated shock. And if decompensated shock is just left unchecked, it ends up with end organ dysfunction and finally death, which we are trying to avoid. And so when I'm thinking about the phases of shock, I don't do the, well, if the heart rate's this and the blood pressure is this, they're in phase whatever, and have lost this much, whatever. I learned that for the boards, then promptly forgot it because I don't find it all that useful. Instead, I like to think about it as a balance between a patient's physiologic reserve and physiologic stress. An 18-year-old healthy guy has a lot of reserve, but if he just lost 5 liters of blood, that's a pretty intensive physiologic stress. On the other hand, a 90-year-old lady with heart failure and renal failure and everything else failure doesn't have a lot of physiologic reserve, but maybe she has a little UTI, so she doesn't have a lot of physiologic stress either. And so at the end of the day, I think about compensated shock as a state where your physiologic reserve exceeds your physiologic stress, and then decompensated shock as a state where your physiologic stress now exceeds your physiologic reserve. So instead of thinking about shock as hypotensive, yes, no, it's a state of blood pressure, I like to think about it on a continuum, where you have some inciting event that puts you in that river in the first place. That causes an intensive physiologic stress, which ultimately leads to tissue hypoperfusion and organ dysfunction, and as we said, death, which you are trying to avoid. Now, There's another thing going on here that we really have to keep in mind, which is states of physiologic stress. You cannot forget that is a sympathetically activated state. Think about what happens when you're physiologically stressed by exercise. What do? You get tachycardic, you get tachypnic, you get diaphoretic, and you get hypertensive. Think about what happens during a stress test. Patients get hypertensive. And in this initial phase of shock, where you're physiologically stressed, that hypertension as a physiologic stress response can mask the ultimate hypotension. Think about those trauma patients, the young, healthy trauma patients. They just had a big trauma. They're in a state of high physiologic stress, and they come in, and everybody's like, the blood pressure is 155 over 100, because we always have to scream that out as loudly as possible. And you're like, okay, everything's fine. And then 10 minutes later, you're like, just kidding, the blood pressure is 70 over 40. And that's what's happening. They were physiologically stressed, they were hypertensive, and now they're decompensating. We've all seen that. But we often fail to notice what it means. But the thing about medicine is just because you fail to notice it doesn't mean it's not there. And what we like to do as doctors is blame our patients rather than ourselves. So we have named something after our own weaknesses, and we call it occult shock. Our patient's sitting there, they're definitely in shock. We're just failing to notice. And really, as far as I'm concerned, the definition of occult shock is when the physician is conflating hypotension and hypoperfusion. We all do it. And I think to avoid doing it in a practical, not just theoretical way, we need to start reframing our mental model of shock around perfusion pressure. Now, this is a non-novel concept. Your mind should not be blown here. This is not the first time or the last time somebody will tell you about this. We've been talking and thinking about this physiology for 100+ years. We do know this. The problem is, it hasn't quite caught on yet at the bedside for a reason. Is because when we are taught about how this works, it looks something like this. This is a diagram I saw in fellowship, and I was like, 100% I see how that applies to my patient at the bedside, applies to the critical care boards, but less easy with your patient. So I'm not coming up with a novel physiology for shock. Instead, what I'm trying to do here is what I like to call advanced simplification. We don't need to reinvent physiology. What we need to do is create a mental model of shock that is both sufficiently sophisticated and nuanced, but also functional for us to use at the bedside. And it's kind of one of these things where we need to figure out how to simplify it so we can connect theory and practice. Because there's a big disconnect about what we know in theory sitting in conference if you're attending Ask You a Question and what we actually do. And the first step is to realize that it is in fact tissue perfusion, not blood pressure, where the magic happens. But if we know that, in theory at least, why are we also obsessed with blood pressure? Now, I think one of those reasons is this one. Measure what is important, don't make what important what you can measure. And that's what we do with blood pressure. It's nice, it's a number, we can measure it. We can be like, if the map is 66, they are not in shock. If the map is 64, they are in shock. We can titrate pressors to a number, to a map of 65. Good luck trying to be able to be like, titrate your norepi to perfusion. That's not gonna work. We like things we can measure, but that doesn't mean that those things are the most important thing. But I actually think that our blood pressure obsession actually runs deeper than that. I think it's a very fundamental human thing that humans are very forward-centric creatures. Just think about when you're on an airplane and somebody has to say explicitly, the nearest exit may be behind you. And yes, this is obvious, but it doesn't occur to us because we are mostly forward-centered creatures as humans. And the problem with this is that hemodynamically, with regard to our hemodynamic worldview, that makes us very map-centric and LVEF-centric. And we are really into the forward pressure. We kind of think about that one as the only one. The problem with that is that if you are so focused on the forward pressure by itself, you are missing the rest of a very complicated system. To really simplify it, think about it like this. You're trying to push a boulder forward, and you're pushing and pushing and pushing, and it's really difficult and it's not working. Either you can push forward, or you can be like, wait a minute, there's another guy on the other side of the boulder pushing backwards, so maybe instead of pushing forwards harder, I can just ask that guy to stop pushing backwards quite so hard. Now, we all know this in theory. Perfusion pressure is forward pressure minus back pressure. And even though we know this in theory, we're like, yeah, but functionally speaking, does it really matter? Because we think of the back pressure as being negligible compared to the forward pressure. But physiologically speaking, that's actually not totally true. So remember this diagram from med school, where we map out the pressure at different levels of the circulatory system. We start with the aorta, arteries, arterioles, we go all the way down back to the veins and the vena cava. And we look at what the pressure does at all those levels. And remember that the capillary level, that is what we care about. That is where the magic of tissue perfusion happens. And then we realize, look where the biggest drop in pressure happens in this system. It is right before the magic happens. And so while we think about the forward pressure as the pressure we're measuring on our A line, up there, the pressure is really high, and so that dwarfs the back pressure we're measuring at our CVP, that is not the forward pressure that's actually driving the pressure gradient across your capillaries, which is the main one that matters. Actually, this one down here, the pressure in your arterioles immediately before the capillaries, that is what's driving this pressure gradient, and it's quite a bit lower. Rather than talking about pressures of 70, 80, 90, we are now talking about pressures of maybe 20 or less. And now all of a sudden, if we compare that to the back pressure that we're seeing on the other end of this, they're not all that different. And so instead of forward pressure dwarfing back pressure, actually, maybe we should be getting excited about backwards instead of just forwards. But there's a third pressure that we need to think about. We have the forward pressure, we have the back pressure. There's another one, the external pressure. So let's say you're on your rock and you've talked to a guy who was pushing backwards into maybe not doing that, but you're still having a really, really hard time pushing it forwards. And then you realize there's a pretty fat dude sitting on top of your rock. And maybe the best way to do this is to ask him to move. Now, we're all familiar with the concept of shock due to increased external pressure, because sometimes it shows up lights blazing, you can't miss it. And what is that? Cardiac tamponade and tension pneumothorax, right? We know this. What is the problem with those two things? Is it lack of forward pressure? No, it's too much external pressure. Now, these are obvious. You're not going to miss these things. But it turns out that sometimes your external pressures can actually be tiny but mighty. And what that is tissue hydrostatic pressure. Because remember, what we care about is perfusion at the level of the capillaries. And the pressure gradient, the pressures right there, are not that high. And so your external pressure, your tissue hydrostatic pressure at that level doesn't have to be that high to matter. So this is what I think of as my 3 pressures approach to shock physiology. Realizing flow and pressure are not the same thing. And what determines flow is actually your pressure gradient. And in order to understand a pressure gradient, you can't just think about one pressure. You have to think about the interfaces between the different pressures you're dealing with. And it allows you to ask interesting questions like, is my problem insufficient forward pressure or excessive competing pressures? Now, that's all very well and good, but to use this 3 pressures model at the bedside, how do we translate this into the patient in front of me? And so what we're going to do is we are going to superimpose our forward, back, and external pressures on a hemodynamic map. And this is going to allow us to look at the interfaces between these different pressures to understand how the physiology of these interfaces work. Now, a lot of this physiology we're about to talk about, you know. In fact, you've probably learned and seen charts and graphs of each individual component of this physiology. But coming out of fellowship, what I felt like I was missing was a way to actually integrate all of those separate things I knew into one vision of the patient that I could use at the bedside to work to clinical problems. So here we are going to try to use back, forward, and external pressure concepts to bring it all together. And we're going to start at the capillaries, because again, that's where the magic happens. And the whole point of this entire system is to get a perfusion pressure gradient across your capillaries. So our first variable, let's just deal with one that we all know and love and we're very comfortable with, the map. And of course, our map is equal, as we all know, to our cardiac output times our SVR. So we have our cardiac output, which is the main forward pressure coming out of the left side of your heart. And then we have our SVR. And our SVR acts as both a forward and a back pressure. It's a double-edged sword here. Why? because it is a fundamental truth of the circulatory system that volume doesn't count unless it's pressurized. This is why we talk about blood pressure, not volume. Central venous pressure, not central venous volume. Your SVR is the main thing that pressurizes this volume, thereby making it useful to us. But there's another side to SVR, because SVR also acts as a back pressure, and it acts as a back pressure towards your left ventricle, a back pressure towards your LV stroke volume. Now, normally, on a normal day, your LV is built to handle afterload. And what you find is that if you increase your afterload from point A to point B, even a fairly substantial amount, your LV stroke volume doesn't drop that much because this is what your LV is designed to do, push against a broad range, even a very high afterload. But this kind of all breaks down when you have a failing left ventricle. If you have somebody with significantly depressed LV function, all of a sudden the curve of how it handles afterload changes. And if you increase the afterload by the exact same amount, what you find is the stroke volume drops significantly more. So this is our LV cardiac output and our SVR, and this interface where SVR acts as both a forward and a back pressure. So our LV cardiac output, what is it made up of? Well, it's made up of our heart rate and our LVEF. Now, in order for our LV to be able to have some kind of stroke volume and move things forward, it has to have something to move forward, and that is our LV preload. Now, this graph we all know very well. This is our Starling curve. And we're looking at, if we start with a normal LV, are you on the steep part or are you on the flat part of your Starling curve? And the idea is, of course, on the steep part, you increase your preload and you increase your stroke volume. Once you're on the flat part, if you increase your preload, you don't increase your stroke volume so much. And so it kind of depends which part you're on. And we have a name for this, which is stressed versus unstressed volume. But if you have depressed LV function, then it's going to look a little different. You have a flatter part that comes earlier of the Starling curve, and increasing your preload compared to a normal LV function gives you a decreased increase in stroke volume. But note that just because somebody has a flatter Starling curve, it doesn't tell you where they are on the Starling curve. And we make this mistake all the time. We do a quick echo, we see the LV function, it doesn't look great, so we're like, we shouldn't give them fluids. But the slope of the Starling curve is not the same as where the patient is at on the Starling curve. Now let's take a moment and revisit the concept of preload, because this is one of the concepts we use most often. You know, think about ICU rounds when you have a sick patient. We use the word preload quite a bit, but throwing it around is fine, but it's actually one of the most complicated variables. So you have preload. And I think often we sort of equate or conflate preload with the amount of volume coming into the right heart. The problem is that's the wrong way to think about it, because as we've talked about, it's not really about the volume, it's about the pressurized volume. And there is, in fact, if you look at the relationship between intravascular volume and the actually physical filling pressures that count, it's not a linear relationship. It's not one for one. You give more volume, that equals more filling pressures and more preload. That's not how it works. It looks like this. So let's say we have a water balloon. And that water balloon starts out with 200 cc's of fluid in it. But in order to fully fill that water balloon, we need 500 cc's of fluid. And so if we put now just 400 cc's, we put another 200 in, but we haven't met the 500 mark, has the pressure in that water balloon changed? No, it hasn't. That pressure only changes once we hit the 500 mark, and now we're at 600, and now the pressure changes as we go along. And this again is our unstressed volume, volume that is not pressurized, it's not usable to us, versus our stressed volume. Now, this is what it looks like on a normal day, but if you suddenly have a patient who's vasodilated, maybe vasoplegic, then you've shifted your bar to pressurize the volume. It's no longer that your water balloon is going to become pressurized at 500. Maybe now it takes 700 cc's of volume to pressurize. So you have now 200, 400, 600 cc's in your water balloon still not pressurized. It's not until you meet the new higher bar, and now you have 800 cc's a liter, that now we are pressurized. So what you've done by vasodilating is shifted some of your unstressed volume into stressed volume. Or really the other way around. If you're vasodilated, you've actually switched some of your stressed volume into unstressed volume. You give pressors, you can maybe switch it back. So when we're thinking about preload, we can't think about the volume returning to the heart. I actually usually think about it as the stressed volume, because that's the only volume that counts that you can use. But there's another variable that determines preload. There is this pesky thing between venous return and the left side of the heart called the right side of the heart. And in order for the left side of the heart to do anything, the right side of the heart needs to hand it that volume to work with. Think about if you're in an assembly line and you're doing a great job, you're chugging along, but the person in front of you in the assembly line is not doing that great. They're going really, really slowly. They're backing up. They're not giving you anything to work with. So the left heart, the left ventricular preload is only as good as your stressed volume coming in and then the ability of your right ventricle to actually move that stressed volume forward. Now, at the interface where your right ventricular cardiac output's trying to move stuff forward into your left ventricle, we have a back pressure. And a very, very important back pressure, that's our pulmonary vascular resistance. And if you look at how the right ventricle handles afterload, not like the left ventricle. So the normal left ventricle actually does pretty well. You can increase the afterload substantially, and the stroke volume just doesn't drop that much. The right ventricle does something very different. If you increase the pulmonary vascular resistance, even a relatively small amount for the right ventricle, its stroke volume drops precipitously. The right ventricle is kind of weak and wimpy. It is not designed to push against afterload. So even though our pulmonary pressures are not that high, even a minor increase in our pulmonary pressures can really affect the net perfusion, or really the net sort of vector of the pressure that's at that interface. Now, the other thing that affects the LV preload actually coming to your left ventricle is the back pressure of your LV end diastolic pressure. If you have, say, a patient with bad diastolic dysfunction, they have a thick, muscular, highly pressurized LV with this tiny, tiny little LV volume, that acts as a fairly substantial back pressure. And if you compare patients, if you look at the LV diastolic volume versus the LV diastolic pressure, normally it's not that big of a deal. Normally, our LV is compliant enough that you can kind of make it work. And so if you increase the volume, the pressure doesn't increase that much. But look at what happens if you have a patient with diastolic dysfunction. What happens to those patients is a small increase in volume translates into a very, very large increase in pressure. But the thing to keep in mind about what happens here in patients with diastolic dysfunction, these functions, these lines, this graph doesn't show hysteresis. It's the same in both directions. So what if you drop the volume by a little bit? If you look at this patient now with diastolic dysfunction, you drop the volume even a little bit, now your pressure decreases precipitously. And these are the patients that come out of the OR or come into the ICU and somebody's like, their blood pressure is really labile, right? That's usually the word. You'll give them a little fluids, they'll go through the roof. Then you'll like stop the fluids and they'll take. Then you give them pressors and they go through the roof and you're just doing this. And it's often, when I see that, I'm like, does this patient have significant diastolic dysfunction, significantly elevated LVEDP, because they're doing this bouncing thing around, because even a small change in volume can translate to a substantial change in pressure. So that is our LVEDP. Now, all of these things now get back and forward transmitted into our ultimate, most important net forward and back pressure, which is, of course, our MAP driving things forward into the capillaries and our CVP driving things backwards. So those are the major forward, backward pressures in our system. They get transmitted down to the level of the capillaries. But we can't forget or ignore our external pressures. So our external pressures, as we talked about, at the all-important level of the capillaries, tissue hydrostatic pressure. Let's take a moment and talk about preload, but not in the context of LV systolic function, in this time, in the context of tissue edema. And it turns out these two things are different. We often think about, oh, if you have high preload, that's the same. It's the same graph relative to LV function as it is to tissue edema. It turns out that's not true. The graph that compares preload to tissue edema looks very different, and it looks like this. The most notable thing about this graph is the inflection point right here. And what this tells you is that if you increase preload, but you're still hanging out before that inflection point, a decent increase in preload doesn't give you a super substantial increase in tissue edema. But what if now you are after this inflection point in the graph? Now what happens? Increasing preload by the exact same amount now gives you a very substantial increase in your tissue edema. So what affects this graph? Is it LV systolic function? It turns out it's not. If we look at the factors that shift this curve to the left, it has nothing to do with LV systolic function. If you look at these two graphs and you have the same starting preload, you increase the preload by the same amount, but the inflection point is at different spaces. Watch what happens. For this first patient versus the second patient, where the inflection point is different, if you increase the preload by the same amount, the first patient, tissue edema doesn't increase that much, but the second patient, it increases substantially. And notice the starting and ending preloads are exactly the same, but the degree of tissue edema, those two preloads and increasing the preload cause are very, very different. Now, what are the things, if it's not LV function, that moves this curve to the left? Well, there's a couple major things. One, capillary permeability. So for example, if the patient, distributive shock, sepsis, any kind of tissue hypoperfusion that's global, decreased oncotic pressure. These are our liver patients. These are our cancer patients, all Marner's patients, and then increased hydrostatic pressure. Our renal failure patients, and often just our generalized patients with volume overload, and of note, nothing to do with LV systolic function. So that's our tissue hydrostatic pressure. And then we have the other big external pressures, our abdominal pressures, the extreme example of which is abdominal compartment syndrome. We have our extreme example of thoracic pressure, and you have a tension pneumothorax, which everybody recognizes, but smaller pressures can also affect this. Think about what happens in a patient with distributive shock when you go up on the PEEP. You go up on the PEEP by 5, and sometimes even just that external pressure, where we no longer have the video because it was apparently feeling under great pressure, now can increase or decrease your blood pressure substantially. And we see that in both directions. If you have a patient in heart failure, volume overloaded, sometimes that can help you. A patient who's hypovolemic and septic shock, that can hurt you. Similarly, we have our pericardial pressure. That can also be dramatic as in a tamponade, or less dramatic as in patients who present with chronic constrictive, progressive constrictive pericarditis. And finally, we have the one that people often forget, which is our septal wall pressure. And septal wall pressure, we also know this concept from RV failure, the idea of ventricular independence. So normally it's supposed to look like this. But we have to keep in mind that the RV and the LV live in the same house, and it's not a flexible house. And so there's this sort of diastolic filling competition that takes place between the LV and the RV. And the more one fills, the less does. Now, on a normal day, it doesn't matter. The LV wins because the pressures are higher in the LV than the RV. But if you either have RV failure, high pulmonary pressures, or you just go bonkers with the fluids and you get a little overzealous, then you start doing something that looks like this. And all of a sudden, the external pressure that your septal wall is placing on the left ventricle, now we have another pressure that is affecting what you get happening in the LV. So this is our map. But there's one thing that we're forgetting, that are easy to forget, that we often forget, which are our valves. Of course, our tricuspid, mitral, and aortic valve are the important valves here, and you need to add these. Because if they are not working, the whole system falls apart. Because this whole system that relies on pressure gradients depend on the valves to make sure the pressure gradients go in the right direction, and that the main variable determining that direction is the gradients themselves. And so if you have a regurgitant valve or a stenotic valve, you really have to wrap around the head that in fact, it is really these pressure gradients and the one-way valves. There's a reason that our circulatory system was designed this way. So let's say you have a regurgitant valve. You can really distill the physiology of a regurgitant valve into 2 key principles. One, dependence, full dependence on pressure gradients. So if your one-way valve has all of a sudden been turned into a 2-way valve, now all of a sudden, the only thing that matters to keep flow going forward instead of backwards is the upstream to downstream pressure gradient. And the net result of that, the downstream consequences of that, is that often these patients will look amazing on echo. Their RV function looks amazing, their LV function looks amazing, but they're actually in high output heart failure. And don't trust that echo because it only looks amazing because it's not pushing against anything. It has a pop-off valve. But why are they in high output heart failure? Because since half of the output is going backwards instead of forwards, they have to work really, really, really hard to get that output to go forwards. Similarly, stenotic valves, two core principles of pathophysiology here. The first is fixed resistance. This is the opposite situation where now, because the valve provides fixed resistance, the pressure gradient from downstream and upstream of the valve doesn't matter so much. We've taken away that pressure gradient dependence with a stenotic valve. And the consequence of this is, because it usually happens chronically, is that our heart adapts. You have alterations in cardiac anatomy and physiology, but these cause our secondary problems. Our LV gets muscular, it gets tight, it gets small volume. Or if we have mitral stenosis, our right atrium or our left atrium blows up, it becomes highly pressurized, and you develop pulmonary hypertension. So our valves, you've got to put on this diagram, they're quite important. Okay, so that is our three pressure shock physiology map. And what I really see this is as a framework to organize my clinical data that I'm constantly gathering from the patient into hypotheses about the factors contributing to their hypoperfusion. And we like to think about patients again in boxes, but I think it's more helpful, for me at least, to think about the factors contributing to shock. Because as much as it would be nice if a patient showed up and was like, I'm committing to hemorrhagic shock today, that would be lovely, but unfortunately, that's not what happens. They develop other kinds of shock. They have mixed shock going on, or maybe they came in with one thing and now you have complications and they have something else going on. So the most useful thing, of course, with this diagram is when I can go back to my complex shock patient and I can take my patient and then I can use my diagram as I gather progressive data and I refine and refine my working hypothesis to figure out what's going on. And it turned out, as we gathered data about Mr. Smith, we realized, one, he was septic. Like, he was truly bacteremic, and it turned out that pretty quickly we grew out some gram positives from his blood. He was vasodilated, his SVR not so good. Then it also turned out, we realized later once we scanned him, the infiltrates on chest x-ray, they weren't pneumonia, they were infected pulmonary emboli. He had all of this inflammation in his pulmonary tree. He had all these little pulmonary emboli that was increasing his pulmonary vascular resistance quite substantially. And as we talked about, the RV does not like that. It gets very upset when it has to push against higher afterload. And so that was decreasing his cardiac output, which was then decreasing his preload and decreasing his left ventricular cardiac output, which was especially a problem because now the low SVR and the decreased LV cardiac output, not a good combination. But then we realized one more thing, because we started sort of treating him for all this, but then I'm looking at him and I'm like, your JVP is up to your forehead. What's going on here? Then we echo him again. And indeed, the LV looked hyperdynamic and underfilled. The RV, if you just looked at it and eyeballed it, hyperdynamic and underfilled, except if you put colored Doppler on it, you realize it's just wide open tricuspid regurg. And that is why the RV looked awesome, because it wasn't really pushing against all that PVR afterload. It was having this pop-off valve that was the tricuspid valve. And what was going on with this guy is he had tricuspid endocarditis. He was bacteremic, so he really was in both septic shock and cardiogenic shock with now high PVRs from septic pulmonary emboli. Now, all of that happens, and of course, your RA pressure goes up. You get that transmitted to your intra-abdominal pressures, your CVP. Now you develop edema, tissue hydrostatic pressure. And so as I was going through this patient, I can make a map of what's going on with him and all of the different things that I would have found difficult if I tried to put him in one of my 4 traditional shock categories. But the really useful thing when the rubber meets the road about this wrap is now that I've mapped out what I think is going on with this patient, it now implies management strategies. So he's septic, his SVR is low, he needs a vasopressor. The RV is really, really hurting here because it's in high output heart failure. But part of the reason it's pretty unhappy and that we're having real problems with the TVR is because the flow is going backwards instead of forwards because, you know, the tricuspid valve's wide open, but the downstream pressure, the pulmonary vascular resistance is high, so we start a pulmonary vasodilator. And then this guy got 3 liters of fluid in the ED. And it turns out the primary thing driving his physiology was less sepsis than this cycle of tricuspid regurgitation, high pulmonary pressures, RV failure, and then all of this tissue edema, which he then develops renal failure. And so he also needed a diuretic. And this more complicated strategy is not really suggested if you sit down and try and put your patient in one of the shock boxes. And a lot of you guys, in fact, most of you probably would have come up with this strategy and eventually realized this, but I find it helpful to have an explicit, systematic mental model for doing this in complex shock patients, especially when I have a complex shock patient that I don't know what's going on. I feel like I thought them through, I've done all the things, and it's just not working. And so I will actually sit down at the bedside with my very messy handwriting and draw this out in a patient that I don't know what's going on. And as I collect more data, as I try more treatment strategies that work versus don't work, I add to my diagram to help me work through what is happening with my patient. And this is something that I found very helpful to do, to get this framework, this scratch pad that I can then use to work through these patients at the bedside. So that's reframing shock. The idea is to help you with a sophisticated, nuanced, but also bedside functional mental model to help you work through complex shock patients. Now, is this easy? Does this require a lot of work? Absolutely. It is much simpler to put your patient in one of 4 categories and call it a day. But I think it's worth our time. I mean, if you think about how we invest our time and the amount of time we spend reading the new literature, looking at the new evidence, the amount of time we spend learning to do and learning about new technologies, and the amount of time we spend looking up and memorizing the latest algorithms and guidelines, we spend a lot of time doing those things. And I think that if we spend an equal amount of time investing in improving our physiologic reasoning abilities, we'll do better for our patients. The end. Thank you guys so much for listening. Questions, comments, strong disagreements, all of the above. I know that was a lot of physiology packed into one lecture. Okay, awesome. Well, I will be around after. Yeah, so this is really hard. I mean, like if you have a swan, it's really, really nice. One of the things that I do functionally, like I can't really estimate the SVR, but one of the things I'll look at the LV systolic function, and then I'll stick them on pressors and reassess it again. And if I think I'm having some kind of forward flow problem and I'm trying to figure out, is my LV failing? Is my SVR not good? The combination of a clinical context that suggests I might have a reason for the SVR being low, and then simultaneously seeing that my LV squeeze looks worse once I increase the SVR, not because the LV got worse, but now it has more afterload. But without a swan, it's really, really hard to assess. And it more has to do with, is that part of my hypothesis? Do I have a reason for it? Because a lot of these things can be difficult to assess at the bedside, although we have a paper that's hopefully coming out in the foreseeable future about this mental model or a similar mental model at the bedside, and actually what ultrasound strategies and other strategies you can use to assess at the bedside. And not sure when it's going to be coming out because we're currently discussing in depth with our reviewers, but that's a great question. Yeah. Yeah. Totally. So this is possibly, I feel like fluid responsiveness may be the most difficult question in all of medicine. And to me, first I draw it out and I decide whether or not I think fluid responsive, because fluid responsive, we talk about preload. And what kind of category do I think my preload problem is? Do I think it's true hypovolemia? Do I think it's, I have plenty of volume, but too much of it is unstressed? Or do I have plenty of stress volume, but the RV is not pushing it forward? So first I try and figure out which of these things is it. And fluid responsiveness is mainly when you're in the category of, I think I have absolute hypovolemia. And so often first I'll be like, does my RV need help pushing things forward? Okay, that's not the case. Do I just need to kind of shift that pressure volume curve that happens when I'm vasodilated? Do I need to shift that back so that I'm making use of the volume I have? Okay, I think I've either done that or that's not my problem. Then now I'm going to assess fluid responsiveness. And in terms of doing that, I feel like it's one of those things, there is no single metric you can hang your hat And I would also say that, I assess a number of metrics. If I can get an LVOT-VTI, if I have good enough windows, I think that's a very helpful thing. IVC, first I have to say, there is nothing that would confound that measurement in either direction because there's a lot of things that would. And then I would also say that often I'm more interested in fluid tolerance than fluid responsiveness. And that's where you get into something like VEXIS, where you're saying it's not just about fluid responsiveness because they're not determined, fluid tolerance and fluid responsiveness, by the same factors. Sometimes you can get a patient who is fluid responsive, but not fluid tolerant. And so trying to balance those two things and say, if I have a patient who is fluid responsive, but not fluid tolerant, how much fluid is it worth to give them? So I feel like this is one of the most complicated questions in medicine. And to me, it determines, by multiple variables. If I have a swan, that's lovely, but most of the time I'm not going to have a swan. Any other questions?
Hey, thanks for the talk. I had a question about approximating your pulmonary vascular resistance, because it seems like it's one of the more difficult variables to sort of guess at. And I was wondering if you had any tips or thoughts on how you approximated that.
This is also a very, very excellent question, and it's very, very difficult. I think that you can use your surrogates. And so actually your pulmonary vascular resistance is difficult. And so I think that your pulmonary pressures is a much more useful thing to have. Now, again, if you don't have a PA catheter in, that is also very difficult to do. But if I do have a PA catheter in, and sometimes if I truly don't know what's going on, or I'm like, this patient is just not getting better, I'll put one in because now I can get a better sense of what my pulmonary pressures actually are. The other thing I do is I say, okay, I know that my RV is very, very sensitive to pulmonary pressures. So also using your RV as a proxy, because if I look at the RV and I'm like, okay, this is a really thick, Olympic trained RV. This patient probably has really high pulmonary pressures at baseline. I'm like, okay, they have very high pulmonary pressures at baseline, but often it means they can handle those pressures. If I don't have an Olympic trained RV, I have a normal RV, and I'm looking at it and it's not blown out, it's not massively volume overload, but it's nice and thin walled, and I look at the TAPSE and the TAPSE's not great, and the RV looks pressure overloaded, but not volume overloaded. I don't know exactly what my past pulmonary vascular resistance is, but I start thinking it's high enough that it matters. If I see septal flattening, now I think it's high enough that it really, really matters. But if I see a big dilated blown out RV without much septal flattening, I'm like, maybe I'm just volume overloaded and my RV is mainly volume overloaded and I'm not seeing systolic septal flattening.